Bipolar disorder, formerly called manic depressive illness or manic depression, is a mental illness that causes unusual shifts in a person's mood, energy, activity levels, and concentration. These shifts can make it difficult to carry out day-to-day tasks. There are 3 types of bipolar disorder. The exact cause of bipolar disorder isn't known, but a combination of genetics, environment, and altered brain structure and chemistry may play a role. Manic episodes may include symptoms such as high energy, reduced need for sleep, and loss of touch with reality. Depressive episodes may include symptoms such as low energy, low motivation, and loss of interest in daily activities. Mood episodes last days to months at a time and may also be associated with suicidal thoughts. Treatment is usually lifelong and often involves a combination of medications and psychotherapy. There are several types of bipolar and related disorders. They may include mania or hypomania and depression. Symptoms can cause predictable changes in mood and behavior, resulting in significant distress and difficulty in life. In bipolar 1 disorder, someone has had at least one manic episode that may be preceded or followed by hypomanic or major depressive episodes. In some cases, mania may trigger a break from reality, which is psychosis. For bipolar 2 disorder, these people have had at least one major depressive episode and at least one hypomanic episode, but they have never had a manic episode. For psychothymic disorder, these people have had at least 2 years or 1 year in children and teenagers of many periods of hypomania symptoms and periods of depressive symptoms, though less severe than major depression. There are other types, which include, for example, bipolar and related disorders induced by certain drugs or alcohol or due to a medical condition such as Cushing's disease, multiple sclerosis, or stroke. Bipolar 2 disorder is not a milder form of bipolar 1 disorder, but a separate diagnosis. While the manic episodes of bipolar 1 disorder can be severe and dangerous, individuals with bipolar 2 disorder can be depressed for longer periods, which can cause significant impairment. Although bipolar disorder can occur at any age, typically it's diagnosed in the teenage years or early 20s. Symptoms can vary from person to person, and symptoms may vary over time. Mania and hypomania are 2 distinct types of episodes, but they have the same symptoms. Mania is more severe than hypomania and causes more noticeable problems at work, school, and social activities, as well as relationship difficulties. Mania may also trigger a break from reality, which is psychosis, and require hospitalization. Both a manic and a hypomanic episode include 3 or more of these symptoms: abnormally upbeat, jumpy, or wired, increased activity, energy, or agitation, exaggerated sense of well-being and self-confidence, which is also euphoria, decreased need for sleep, unusual talkativeness, racing thoughts, distractibility, and poor decision-making. For example, going on buying sprees, taking sexual risks, or making foolish investments. A major depressive episode includes symptoms that are severe enough to cause noticeable difficulty in day-to-day activities, such as work, school, social activities, or relationships. An episode includes 5 or more of these symptoms. Depressed mood, such as feeling sad, empty, hopeless, or tearful. In children and teens, depressed mood can appear as irritability. Marked loss of interest or feeling no pleasure at all, or almost all activities. Significant weight loss when not dieting, weight gain, or decrease or increase in appetite. In children, failure to gain weight as expected can be a sign of depression. Either insomnia or sleeping too much, either restlessness or slowed behavior, fatigue or loss of energy, feelings of worthlessness or excessive or inappropriate guilt, decreased ability to think or concentrate or indecisiveness, thinking about, planning, or attempting suicide. There are other features of bipolar. Signs and symptoms of bipolar 1 and bipolar 2 disorders may include other features such as anxious distress, melancholy, psychosis, or others. The timing of symptoms may include diagnostic labels such as mixed or rapid cycling. In addition, bipolar symptoms may occur during pregnancy or change with the seasons. The two different measures I selected for use with the bipolar population are the Mood Disorder Questionnaire and the Beck Depression Inventory. The Mood Disorder Questionnaire is a 15-item self-report screening instrument that can be used to identify clients most likely to have bipolar disorder. The MDQ assists in identifying bipolar disorder and distinguishing it from other mood disturbances in clinical populations. Past research has found that MDQ total scores are associated with anxiety, trauma-related substance use, eating, and impulse control disorders, in addition to bipolar disorder. As a result, there have been two subscales identified. Positive activation, which includes increased energy and activity, grandiosity, and decreased need for sleep. This subscale is specific to bipolar disorder. And negative activation, which includes irritability, racing thoughts, levels of negative affectivity, and distractibility. This subscale is more broadly related to emotion dysregulation and transdiagnostic personality traits. Research indicates that effective treatment of bipolar disorder differs significantly from that of other related disorders, such as unipolar depression. This underscores the importance of screening for bipolar disorder in patients who present to mental health services so that they can receive an effective intervention. For example, the use of antidepressants in bipolar treatment is controversial, and psychotherapy treatment more often involves addressing issues such as unrealistic goal setting and impulsivity in patients with bipolar than in others. As bipolar disorder is associated robustly with significant psychosocial impairment, for example, poor work and relationship functioning, failing to detect cases of bipolar disorder can lead to suboptimal treatment approaches and thereby exacerbate personal and societal costs associated with bipolar. The psychometric properties for the MDQ are as follows. The internal reliability for the MDQ is strong. Traditionally, a positive screen on the MDQ requires endorsement of 7 or more of 13 symptom items, multiple symptoms occurring at the same time, and symptoms causing notable psychosocial impairment. The first 13 questions on the MDQ are based upon bipolar symptoms, and a score of 7 or more is the optimal cutoff, as it provides good sensitivity and very good specificity for a diagnosis of bipolar. However, results from a number of studies suggest that the MDQ is not unidimensional. Carpenter and Stanton and Watson investigated the structure of the MDQ's 13 symptom items and found that the MDQ was best represented by two factors, which they termed positive activation, for example, had much more energy, was much more confident, and negative activation, for example, thoughts raced or felt very irritable, symptom dimensions. 3 of the MDQ symptoms, items 5, 10, and 11, loaded highly onto both positive and negative activation factors and were removed from the final model. Carpenter found that positive activation was uniquely associated with bipolar diagnosis, whereas negative activation was associated with a range of diagnoses. Thus, a 4-item positive activation subscale and a 6-item negative activation subscale was created. For scoring and interpretation, we have a total score is calculated for questions 1 to 13, where a yes provides a score of 1 and no is 0. The percentage of items endorsed, raw score, or number of items multiplied by 100 is included to provide an indication of the proportion of symptoms identified with by the respondent. In order to meet the threshold for bipolar disorder, the traditional scoring method is as follows. A score of 7 or more for questions 1 through 13, and check yes for the item asking if the symptoms clustered in the same time period, question 14, and symptoms caused either moderate or serious problems, which is question 15. Subscale scores were also developed using 10 of the 13 items in the symptom questions. Positive activation assesses increased energy or activity, grandiosity, and decreased need for sleep. Individuals endorsing symptoms defining positive activation are not likely to report significant levels of negative affect and are likely to be energetic and extroverted. Individuals scoring high on positive activation may be less likely to rate their symptoms as impairing, given that increased levels of energy and activity may be experienced as advantageous to some degree, especially if they are mild in nature. This factor is strongly associated with a BD diagnosis. Negative activation, items 1, 2, 6, 7, 12, and 13. Assesses irritability, racing thoughts, levels of negative affectivity, and distractibility. This factor is strongly associated with bipolar as well as a range of other disorders, many of them, for example, depressive disorders, PTSD, generalized anxiety disorder, substance use disorders, characterized by emotion, dysregulation, and/or transdiagnostic personality traits such as neuroticism and disinhibition. Clients high in negative activation may be at risk for engaging in impulsive behavior in emotional situations. Clinical percentiles are also presented for the 2 subscales as developed by Carpenter on over 1,700 outpatients for a variety of diagnoses. A percentile of 50 means that the client has scored at the average level compared with the clinical group for that subscale. And the second measure I selected was the Beck Depression Inventory. The Beck Depression Inventory is a 21-item self-report rating inventory that measures characteristic attitudes and symptoms of depression. The BDI has been developed in different norms, including several computerized forms, a card form, the 13-item short form, and the more recent BDI-2 by Becksteer and Brown. The BDI takes approximately 10 minutes to complete, although clients require a 5th to 6th grade reading level to adequately understand the questions. Internal consistency for the BDI ranges from 0.73 to 0.92 with a mean of 0.86. Similar reliabilities have been found for the 13-item short form. The BDI demonstrates high internal consistency with alpha coefficients of 0.86 and 0.81 for psychiatric and non-psychiatric populations, respectively. I would utilize these measures in my counseling sessions with bipolar clients to see how they were doing in relation to their disorder. The Beck Depression Inventory would give me a good idea of whether or not my client is suffering from depression, and the Bipolar Mood Disorder Questionnaire would help with manic or mania-related symptoms of the disorder. The strengths of the Beck Depression Inventory include it is easy to complete and it covers a lot of different aspects of depression. Some limitations include the weight given to each question or bullet on the inventory. One limitation of the Mood Disorder Questionnaire is that it is self-scoring, which can make clients rethink their answers when scoring and wonder if the score they get is truly accurate to what they are going through. A strength of the Mood Disorder Questionnaire is that it is brief and easy to complete. It is important to note that neither of these questionnaires or inventories are good enough to take the place of a true diagnosis from a professional psychiatrist.